Welcome back. Well, we are in discussion with Dr. Dalal as well as Dr. Bajaj on the topic of menopause. Well, Dr. Dalal, I'm going to touch upon the topic of hormone replacement therapy now. Give us a sense in terms of who is eligible for it and what are the risks of HRT?
See, today we don't call it HRT, it is menopausal hormonal therapy to remove the stigma.
Okay.
So, it is there for people who have severe vasomotor symptoms, hot flashes, night sweats, vaginal dryness. If you are low risk, you do not have a family history of a breast cancer, ovarian cancer or any DVT and venous thromboembolism and things like that which are risk factors. If you have a sonography which is normal, your endometrial thickness is below 4 millimeters, your ovaries are normal, you don't have any pathology which can go bad because of your estrogen, your breast examination, your mammography is normal. I know that one more test which is always done at menopause is your DEXA. Now, it is very important at that time because if this DEXA scan is already showing an osteopenia or a osteoporosis at the start of menopause, these are the women who will definitely also be benefited.
Okay.
So, when I am saying that it is for vasomotor symptoms, yes. So, the mantra today is you give as less as possible for as long as possible, as she needs, not possible. We used to believe that if you give the smallest dose for at least the smallest amount of time, which was around 5 to 10 years, the benefits lasted for a long time. Today, the belief is that you give the least possible dose for as long as she needs. You are nobody to judge. The rule is she has to follow rightly, that annual screening has to be done to make sure that there is nothing happening in your uterus, your breast or anything. Second thing is, you don't always have to take oral. It can be local, it can be dermal, it can be in any way that there are many forms of estrogen to be given. Whenever the uterus is there, you have to understand you have to be given progesterone in some form, whether it is an oral progesterone which is given, whether you have had a Mirena inserted or whatever. It cannot be unopposed estrogen. It has to be given with progesterone, whether it is a low dose daily, 14 days in the month. There are various protocols and there are various estrogen preparations that are available. Okay. If you want, this will look after your hot flashes, it will look after your vaginal dryness, but if you genuinely want it to benefit in your osteoporosis, it will benefit for your cardiovascular protection as well as osteoporosis if it is begun as soon after menopause. You know, within 10 years of menopause, if you have started it, then it is going to benefit you. You cannot say I am 60 years old, 10 years menopausal, now I have osteoporosis and now give me estrogen. That is not the first choice at that age.
Okay.
So, if you start early for a particular symptom, monitor, then only it is not a bad word.
All right. Dr. Bajaj, what if somebody is not eligible for HRT? What would you recommend to them then?
First of all the lifestyle changes like I told you. Then there are alternatives like phytoestrogens. You know, like Dr. Dalal was saying, these Japanese do not have, Koreans don't even have a word for hot flashes because the diet is so rich in soya. So soya is a good source of phytoestrogen. She can take that, omega-3, evening primrose oil. And if you divert yourself and you're attentive, I mean, do the other things, and then there should be some support from your family at your workplace also.
All right. Breast cancer, cardiovascular diseases, or maybe even other cancers, as well as osteoporosis. What are the chances of it increasing post-menopause?
Let's put the cancer apart. Osteoporosis and cardiovascular disease is a given. Every woman who after menopause your estrogen goes, if your estrogen is not there, your cardio protection as well as your bone protection goes away. Estrogen has these two effects. As far as the bone is concerned, 100% your bone is starting to be resorbed. Up to 10% of the bone goes in the first say 5 to 10 years, which is a given. So, you know that once you're menopausal, you are going to have these two. Now, cancer is not related to menopause.
Okay.
It is an age-related thing. In many cases, you know, you find that the elderly women do get some cancer or the other. You may be having a genetic predisposition, you may be having some risk factors which you are, you know, having, that is why you are going to get this. See, one thing I want to tell you is the number one risk factor today is obesity. As she very rightly said, even postmenopausal bleeding, endometrial thickness, where is the estrogen coming from? Most of the times it is obesity.
Okay.
So that's why I urge women, start walking. We are not telling you to spend for gyms, and you can do that if you want to, wonderful, but at least start walking. It will prevent osteoporosis, it will prevent so many, you know, instability, because your muscle strength improves. So osteoporosis and cardiovascular disease, 110% will occur after menopause. So we have to do. Estrogen doesn't only, you know, how does it have an effect? It is not, it has both sides. It prevents bone loss, it helps in bone formation, it helps in calcium absorption. You know, it prevents calcium excretion. I'm very layman's term. And it directly has an effect on the bone. So imagine, if that has gone, you have lost that protection.
Okay. Okay. All right. Dr. Bajaj as well as Dr. Dalal, it's been a pleasure. We have a lot more to discover within this topic, but thank you very much for joining in and speaking with us today. Thanks very much.
Thank you for inviting us.